Papillary thyroid carcinoma is the most common malignant thyroid neoplasm. Its incidence has been increasing in the last decades, doubling since the 70s due to the diffusion of screening ultrasound. Although this kind of cancer is considered a slow-growing tumor, the incidence of node metastasis is high, ranges from 20 to 90%. Indeed, the real impact of node metastasis on prognosis is still a matter of debate. In fact, reports in the literature demonstrate a reduction of disease-free survival, but are divergent on overall survival. As we know, diagnostic tools have a poor accuracy for central lymph node compartment, which is the most frequent site of metastasis. The current guidelines, including the American Thyroid Association guidelines and the NCCN guidelines, suggest a prophylactic central lymph node compartment dissection in patients with high-risk papillary thyroid carcinoma. But this indication meets resistance due to the higher incidence of postoperative complications, including hypoparathyroidism and recurrent laryngeal nerve palsy. As we know, nowadays molecular biologic techniques have spread widely, mainly in diagnosis of node metastasis in breast carcinoma. These assays allow to quickly isolate, amplify, and quantify the mRNA coding for proteins selective present in neoplastic cells, as the CK19. Nowadays, one-step nucleic acid amplification, OSNA, is routinely used in diagnosis of node metastasis in sentinel lymph node of patients affected from breast cancer. The aim of our study is to evaluate if application of OSNA to intraoperative diagnosis of node metastasis of papillary thyroid carcinoma is possible. In our study, we enrolled patients with preoperative cytological diagnosis of PTC. The patients underwent surgery at our department from 2018 to 2020. We performed neck ultrasound routinely preoperative. We included in our study both patients with clinical uninvolved lymph nodes and those with preoperative or intraoperative findings of node metastasis. All the patients underwent total thyroidectomy associated to central lymph node dissection, and in case of preoperative studies positive for lateral cervical lymph node metastasis, to modified radical lateral neck dissection. From each patient, we randomly selected one or more lymph nodes among those excised for lymphectomy to be included in our study. Each collected lymph node was weighed and measured, and then divided into halves. The first one was analyzed with histopathological and immunohistochemical examination, and the second was studied with OSNA. The first half was fixed with formaldehyde. Sections were then stained with HNA, and immunohistochemical analysis was performed with streptavidin biotin technique on paraffin section using an anti-pancytokeratin antibody. According to manufacturer's instructions, the second half was homogenized in an mRNA stabilizing solution, namely Linorac. The homogenate was briefly centrifugated and directly used as a template for reverse transcription loop-mediated isothermal amplification. Amplification of CK19 mRNA was automatically performed in a dedicated instrument from Sysmex. Results were presented in a number of CK19 mRNA copies per microliter. Depending on the number of copies per microliter, OSNA test was defined as negative in case of a number of copies of less than 250 copies per microliter, or positive in case of a number of copies greater than 250 copies per microliter. Positive results were then classified as micrometastasis or as macrometastasis in case of a number of copies greater than 5,000 copies per microliter. Then we compared the OSNA results to histopathological examination, which is the gold standard test, and based on the matching between the techniques, we identified the true positive results, true negative results, false positive and false negative results, and then we define sensitivity, specificity, positive predictive value, negative predictive value, and accuracy. We included in our study 53 patients, 10 males and 43 females, with preoperative diagnosis of papillary thyroid carcinoma with a mean age of 44 years. The total number of lymph nodes included in the study was 114, thus with a mean number of sampled lymph nodes from each patient of more or less 2 lymph nodes. The sampling site was the 6th level in 34 cases, peritoneal lymph nodes in 31 cases, the 7th level in 13 cases, the right third level in 13 cases, the left third level in 9 cases, and the right second level in 4 cases. The total weight of the sample, the mean weight of the sample was of 210 milligrams, and the weight of OSNA sample was 113 milligram. The size of the lymph nodes arrested was of 10 millimeter in length and of 5 millimeter in the height. In this table, we can observe the results of histopathological examination and of OSNA. So we had a total of 114 lymph nodes arrested and examined, and histopathological examination demonstrated lymph node metastases in 35 lymph nodes and the absence of metastatic cells in 79 lymph nodes. Regarding OSNA, we found a positive test in 35 patients, of which 29 with micrometastasis and 6 with macrometastasis, and a negative result in 79 lymph nodes. We had 70 cases of true negative result of OSNA, 32 cases of true positive result, 4 false negative results, and 3 false positive results. So the sensibility of OSNA was of 87%, the specificity was 94%, the positive predictive value was 87%, the negative predictive value was 94%, and finally the accuracy was of 92.3%. The prognostic value of lymph node metastasis in papillary thyroid carcinoma is still a matter of debate. In fact, if some authors have shown that lymph node metastasis do not increase survival rate, others have suggested that lymph node involvement is a significant prognostic factor affecting both disease-free survival and in some cases also overall survival rate. Consequently, also the optimal extent of cervical infectomy remains controversial. In the past, infectomy was reserved to patients with clinically involved lymph nodes and consisted in radical neck dissection. Nevertheless, the most frequent site of neck metastasis is the central neck compartment. Ultrasound is the gold standard in diagnosis and preoperative evaluation of papillary thyroid carcinoma, but its accuracy in detecting node metastasis of the central compartment is low due to technical limits because of the presence of air in the trachea, which hampers diffusion of ultrasound. For the reasons, in the last decade, the New York guidelines on thyroid cancer have suggested that prophylactic central lymph node dissection for patients with high-risk papillary thyroid carcinoma and clinical uninvolved lymph nodes, consisting in excision, perithyroidal, precricoid, and recurrent lymph nodes. Supporters of this approach suggest that selective lymphadenectomy is not sufficient as it is associated with a greater risk of local relapse. Thus, prophylactic central lymph node dissection allows to reduce the necessity of second surgery rather than providing a better staging of the tumor. By the other side, many authors have shown that this approach is associated with higher incidence of transient hypoparathyroidism and recurrent lymph laryngeal injury. Also, considering that the real impact of metastatic lymph node on prognosis is doubtful, this author discouraged prophylactic central lymph node dissection as a routine approach. In this scenario, finding new diagnostic tools which allow to identify preoperative or intraoperative lymph node metastases seems to be of considerable importance. Sentinel lymph node, as we know, is the first tumor lymphatic and drainage station. Sentinel lymph node biopsy permits to assess nodal status and to decide the proper treatment for regional lymph node stations. In fact, if a sentinel lymph node is positive, lymphectomy of the affected compartment is performed. This approach is routinely used for breast cancer and recently has been proposed also for papillary thyroid carcinoma. Several methods of intraoperative analysis of sentinel lymph nodes in papillary thyroid carcinoma have been tested, including frozen sections and non-thyroglobulin measurement, resulting in stronger results between intraoperative analysis and definitive histopathological findings, with poor values of sensitivity and specificity. Then in the last few years, molecular biology techniques have been introduced to identify tumor-specific markers. Among these, reverse transcription polymerase chain reaction is used to identify tumor-specific mRNA and is useful to detect lymph node metastases. Unfortunately, this method is not suitable for clinical practice due to its complexity and its consuming nature. The OSNA method was first described by Tsujimoto and colleagues to detect node metastases in breast cancer. This technique allows to quickly isolate, amplify, and quantify mRNA encoding for CK19. A single examination takes 30 or 40 minutes, is highly automated, and does not require sterile working conditions. This makes OSNA suitable for intraoperative examination. The excellent accuracy of OSNA in detecting node metastases in breast cancer has been shown in several clinical studies. Later, OSNA has been shown effective in detecting lymph node metastases from other types of tumor, such as colorectal carcinoma, endometrial carcinoma, gastric carcinoma, and head and neck squamous cell carcinoma, and lung carcinoma. In a pathological study of two, the author reported that CK19 is strongly expressed in the cellular membrane of over 70% of papillary thyroid carcinoma, and this positivity is also seen in metastatic cells within the lymph node. CK19 is not present in other elements of the lymph node. Thus, CK19 is eligible as a marker of metastasis of PTC. These considerations have led us to validate OSNA as a diagnostic tool evaluating lymph node status in PTC. We decided to compare OSNA results with the gold standard diagnostic method represented from histopathological examination. In our study, we analyzed 114 lymph nodes from 53 patients. For the purpose of our study, each lymph node was considered as an independent case. Results of OSNA and histopathology were according in 92% of cases. In fact, 32 lymph nodes were positive both on OSNA and on histopathological examination, while 75 lymph nodes were both negative on OSNA and on histopathological examination. We found discordant results only in 7 cases. In 3 cases, OSNA was positive for macrometastasis, while histopathological examination didn't find any metastatic cells. We found the opposite result in 4 lymph nodes, with histopathological examination demonstrating macrometastasis. These findings could be explained by the fact that metastatic deposits are often small and irregularly distributed within the lymph node. In our study, half of the node was analyzed with OSNA and the other half with the histopathological examination. Thus, the same slice cannot be analyzed with both the techniques. It's likely that in discordant cases, metastatic cells were restricted to the half which was analyzed with OSNA or histopathology, respectively. In this regard, it seems important to underline that histopathology examination is performed on each lymph node with a single H&E section. It's possible that the half lymph node analyzed with histopathological examination was containing small foci of carcinoma that were not included in the analyzed section, resulting in a false positive result. Thus, it's reasonable that the number of positive lymph nodes is underestimated by histopathology. By the other side, OSNA allows to evaluate the entire lymph node, enabling to detect a greater number of small metastatic foci, as reported for breast cancer from Osako and colleagues. In fact, as already stated, classic histopathological examination is usually performed only on one section of the lymph node. To small foci of metastasis could be misdiagnosed because they are not included in the analyzed section. Results could also be related to a low expression of CK19, as it is the only marker used in OSNA assay, as reported for breast carcinoma. It would be very interesting to perform OSNA on the whole lymph node as is done with breast cancer. Unfortunately, this was not possible in our study due to legal and ethical reasons, because OSNA is still validated as effective in detecting node metastasis in PTC. Overall, our study demonstrated that OSNA has a high accuracy in detecting lymph node metastasis of PTC. In conclusion, our study confirms that OSNA is effective in detecting lymph node metastasis of papillary carcinoma. Considering the higher risk of complications in central lymph node dissection and the uncertain and prognostic value of lymph node metastasis of papillary carcinoma, OSNA seems to be a promising tool to identify patients who may benefit from central lymph node dissection to perform a tailored surgery. Considering the accuracy of OSNA, future studies should provide analysis of the whole sentinel lymph node with this method. Thank you very much for your attention.